This video examines hospital patient flow, moving beyond the common misconception that it is merely a bed problem. Instead, we explore the systems-based approach to understanding and managing flow from the emergency department through to discharge. We cover 6 core sections over 45 slides. We address why simply adding capacity often fails, the underlying science of flow, how to diagnose current systems, and evidence-based redesign strategies to improve patient care. Our first section focuses on the case for change. The fundamental argument here is that systemic waits and delays are not inevitable, and they cannot be fixed by simply buying more beds. For too long, delay has been treated as a design assumption. Hospitals have historically responded to demand by adding resources, but modern research shows this rarely resolves the underlying inefficiencies. Trying to widen the front end of a funnel without addressing the neck is ineffective. As this slide illustrates, while population has grown significantly, relative inpatient bed capacity has fallen. Flow remains our most critical lever. Poor flow carries a direct cost to patient safety. Issues like boarding patients in inappropriate areas, stretched staffing ratios, and off-service care are shown to negatively impact patient outcomes. Beyond safety, poor flow leads to lost revenue and reduced access. Boarding consumes vital capacity and increases the cost of care, effectively robbing hospitals of the resources needed to serve their communities. Recent data confirms that boarding has become a normalized, systemic issue. It is now recognized as a public health emergency, with long boarding times identified as the primary driver of hospital crowding. The harm caused by boarding is not just anecdotal, it is measurable. Studies confirm higher risks of care errors, increased mortality, and significant negative impacts on physician and staff well-being. It is important to recognize that the emergency department is often just where the symptoms manifest. The root cause is typically an inability to move patients out of the ED into appropriate inpatient care. Redesigning the system is key. Berwick's law of improvement reminds us that every system is perfectly designed to achieve the results it gets. We must focus on work processes rather than expecting staff to simply work harder. Moving to Section 2, we discuss the science of flow. Here, we analyze how variation, rather than the inherent randomness of disease, acts as the primary engine for delays in healthcare. To improve, we must accept where variation truly comes from. While random arrivals occur, the variation introduced by internal delivery system structures is far greater, meaning we have the power to design our way to better performance. We distinguish between natural and artificial variation. Natural variation, such as patient arrival times or disease severity, is statistically predictable in aggregate and must be managed using data and robust queuing methods. Conversely, artificial variation, driven by individual habits, preferences, or inefficient scheduling, should be eliminated. This type of variation creates unnecessary bottlenecks and requires a standardized approach to optimize system flow. We categorize variability into 3 sources: clinical, flow, and professional. While random clinical variability must be managed, non-random professional variation, like surgeons' preferred scheduling, should be systematically eliminated to improve overall flow. There is no such thing as a hospital with zero variability. Litvak's test shows that total elimination of variability would require identical patients, perfect arrival regularity, and perfectly identical providers. Since this is impossible, our goal is to design for variation. The quote, elective paradox reveals that scheduled admissions often impact flow more significantly than emergency arrivals. Because surgical slots are often assigned arbitrarily, they frequently fail to account for the actual bed (ICU) and staff resources required downstream. Averages often camouflage systemic issues. As this comparison shows, 2 hospitals can have the same weekly volume, but the one that clusters cases disproportionately will face recurring capacity crises and delays, regardless of its average metrics. Batching cases leads to the quote, pig in the python effect. When cardiac surgeries are concentrated on specific days, the ICU is overwhelmed on those days and left underutilized on others. Smoothing these arrivals makes the demand plannable. Queuing theory dictates that as utilization nears 100%, waiting times do not rise linearly, they explode. High census hospitals are fragile by mathematical design, not necessarily by mismanagement, making full utilization a dangerous goal. Even with sufficient average capacity, random arrivals and variations in case duration cause queues. Therefore, the manager's true objective is not maximum utilization, but minimizing total cost by properly sizing buffers for remaining natural variation. We now move to Section 3, where we discuss the importance of diagnosing the system before implementing changes. By asking the right questions and tracking the right measurements, you can identify precisely where your flow is broken. To reveal a flow problem, ask 2 questions. Do you frequently park admitted patients elsewhere? And do you start your day at 90% capacity or more? A yes to either confirms that flow improvements are urgently needed. When measuring variation, look through 2 lenses, within day and between day. Within day variation often points to issues with discharge timing, while between day variation is typically driven by elective scheduling. Each lens directs you to a different solution. Before you intervene, identify the true constraint. Hospitals are networks of processes. The bottleneck isn't always where you expect. Often, an underutilized operating theater is simply a symptom of a downstream ICU that has reached its limit. Finally, stand up a flow dashboard. Use it to display variation, not just averages. Track metrics like ED boarding, discharge timing, and census variation. Review this weekly in a system-level flow huddle to ensure your improvements are data-driven. We now enter Section 4, Redesigning Flow Inside the Hospital. This section explores 7 evidence-based changes tested by over 60 hospitals to help you systematically optimize your internal processes. These 7 changes are organized into 3 areas: smoothing demand, mastering the discharge, and shrinking internal demand. Each is a high-leverage move designed to stabilize your system and improve both staff and patient experience. The first change is smoothing the elective surgical schedule. Because elective surgery is a major source of artificial variation, you must level the volume across the week to ensure predictable downstream demand for beds and ICU resources. The second change is to separate emergent from elective surgery. By dedicating specific rooms for emergency cases, you shield the scheduled elective stream from last-minute cancellations, creating predictable utilization and better outcomes for all patients. This approach is proven at scale. At Cincinnati Children's, separating these streams and smoothing elective schedules generated significant annual revenue capacity, reduced operational costs, and allowed the hospital to avoid a major, costly capital expansion. The third change is to schedule the discharge itself. By assigning a specific time to every discharge, you move from an ad hoc process to a planned one, which synchronizes other hospital functions and prevents exit bottlenecks. Once a discharge time is set, you can orchestrate the entire day. Lab tests, pharmacy needs, and transport activities converge around that target, creating a continuous, smooth flow of departures rather than a late afternoon scramble. For complex cases, use a dedicated team to manage discharge planning. These patients often face unique placement barriers. Having a focused team ensures they receive customized, effective solutions without disrupting the standard flow of the unit. The fifth change is to synchronize all hospital moves to the discharge schedule. Whether it's internal ICU transfers or new ED admissions, everything should align with planned discharge times, optimizing the system's capacity as a whole. Sixth, use rapid response teams to intercept demand early. By catching clinical soft signs before a full arrest occurs, you can stabilize patients on their own wards, preventing unnecessary ICU admissions and preserving critical care capacity. Finally, shrink ICU length of stay with care bundles. Implementing evidence-based protocols for ventilated patients significantly reduces stay duration, effectively adding ICU capacity without the expense of new construction. Section 5 addresses extending the chain. Flow problems and their solutions rarely stay within the hospital walls. We must look at how we engage with post-acute providers and community resources to manage the entire continuum. We must build the capacity we are missing outside the hospital. If chronic ventilator patients are stuck because the community lacks specialized beds, hospitals should help establish that capacity rather than simply suffering from the bottleneck. This also applies to the front end. By using on-site providers to treat nursing home patients where they live, we can prevent ED visits entirely. Additionally, establishing reservation-style bed agreements with post-acute facilities streamlines back-end discharges. In Section 6, we cover the modern toolkit, integrating real-time data and AI with the foundational principles of flow to achieve sustainable system improvements. Capacity command centers function as the cockpit for hospital flow. By centralizing bed management and using real-time analytics, these centers provide the oversight needed to drastically improve transfer times and morning discharge rates. Technology, however, is not a silver bullet. AI and predictive analytics provide powerful insights, but they work best when paired with rigorous flow discipline. Today, policy and industry standards are increasingly prioritizing these capacity-building metrics. To start your flow journey, follow this 90-day agenda. Measure for 30 days, diagnose constraints for 30, and test redesigns for the final 30. Remember, system results are a design choice. Start your redesign today.